Morning. We're going to get started because it's 7:30. So today I'm going to be introducing our Grand Round speakers. I'm very excited to introduce our panel of speakers today who will be discussing functional neurological disorders. There'll be 4 speakers today, and the first speaker is Dr. Zakaryan. He's a licensed clinical psychologist who specializes in pediatric pain management. He has been with Phoenix Children since 2017 and clinically focuses on treating youth with chronic pain along with their families. Dr. Zakaryan also helps run the weekly rehabilitation and pain program for adolescents suffering from chronic pain. Next, we'll hear from Dr. Montano. Dr. Montano is a licensed clinical psychologist who is part of the Consultation Liaison, or CL, team at Phoenix Children's. She has been at Phoenix Children's since 2020 and became passionate about working with patients with functional neurologic disorders through her work on the CL team. Through this interest, she collaborated with stakeholders across the hospital to create an FND clinical guideline to guide and standardize the care we provide to patients with FND. Our third speaker will be Dr. Kahlon. Dr. Kahlon is a board-certified pediatric neurologist with extensive training in general and autoimmune neurology, as well as in diagnosing and treating pediatric movement disorders. She is also a member of the American Academy of Neurology, the Child Neurology Society, and the International Parkinson and Movement Disorder Society. Finally, we will hear from Dr. Genovese. Dr. Genovese is a pediatrician dedicated to making the lives of children more comfortable. Holding board certifications in general pediatrics, pain medicine, palliative care, and hospice care, Dr. Genovese provides well-rounded, comprehensive care to her patients. She is also trained and skilled in acupuncture, craniosacral therapy, visceral manipulation, and neuromeningeal manipulation. Dr. Genovese is actively involved in research to improve quality of life in the fields of pediatric pain medicine, hospice, and palliative care. Please join me in welcoming our speakers.
All right. Good morning, everyone. Thanks for joining us bright and early this Tuesday morning. We're really excited to be here to talk about the fundamentals, FNDamentals of evaluation, treatment, and other discussions for our patients and families. So kind of to get started, what we want to do, we want to be able to identify as our objectives different components of the multidisciplinary evaluation and treatment for patients and families with FND. Then identify 2 to 3 ways to improve communication to these patients and their families. One kind of being how to frame talking about FND amongst all the different stakeholders that are going to be part of it. And 2, how to weave in different organic symptoms that can be occurring and the FND symptoms together. So we could each of us talk of an hour or more with these topics about in our fields of expertise, but we're going to try to kind of hone in on it. We could also have a lot of other colleagues that could have been joining us too from PT, OT, OMT, and everyone else. So we want to kind of acknowledge that there's a lot of folks who end up taking care of these patients and families. So we're not going to get into too much, but just kind of putting us into context, right? So the Diagnostic and Statistical Manual, DSM-5, and this FND falls under the somatic symptom and related disorders. And so kind of just highlights all of these batches of disorders, the prominence of different somatic symptoms and or illness anxiety that gets associated with a lot of distress and impairment. So we're going to, again, we're not going to call it FNSD just for the sake of kind of having one name throughout. So we'll focus on FND. And then also thinking about how maybe sometimes other symptoms like pain could be more maybe kind of thought of as a somatic symptom disorder with a subject specifier called somatic symptom disorder with predominant pain. Again, not going to focus too much on it, but just knowing that we know altered voluntary motor or sensory function, not better explained by another medical or mental disorder. And these deficits are causing a lot of distress. And then there's these different symptom types that are there that can be part of the diagnostic process. And also additional specifiers you'll see at the bottom, whether they're acute under 6 months or more long-standing beyond 6 months, and with or without psychological stressors. So that's a big factor that we are going to kind of have as a take-home point, that it does not require a stressor, and that kind of helps illustrate that. So think of like more of the why and what's important about FND is that in a number of clinics or different kind of research studies, FND ended up being like the second most common diagnosis seen in outpatient neurology clinics, especially when we think about like our movement disorder clinics and things and colleagues who are in there. And then here at PCH, especially for our general CL psychology, it's one of the top 3 consults that we get, and at least about 8 a month. Again, depending on when we expand or narrow that kind of scope of how what kind of functional symptoms that might come through, but at least FND wise, it's that much. And most of the research is going to be supporting a multidisciplinary approach to treatment. So at Phoenix Children's, when we went back in a small batch of these consults that came through, the average number of consultants and specialists was about at least 5. So that's a lot of folks who are getting involved, and that's beyond, of course, the hospitalist and people like child life and social work. So there's a lot of folks who are and resources being utilized for these patients. So we want to kind of be strategic and thoughtful about how we communicate, but also the use of our resources. And one of the recent research studies had looked, and this was, I think, before COVID, even that the cost for adults and children with FND in the healthcare system was above $1.2 billion a year. So again, a significant notice of like healthcare utilization. So we have to acknowledge that. But even more so, and what's kind of, I think, more at our heart is that we see how much of a disruption this is and how impairing this is for our patients and their families. Kids not being able to go to school, not being able to participate in their daily activities, parents who might have to take FMLA or have to be off of work, or put a pause on their jobs and like the care of their other children to make sure that they are able to get care for their child who is dealing with FND in this system that doesn't always fully understand it. Also, you know, we know that this isn't going to be a huge focus for patients' understanding or like, you know, in the mainstream in that way, and for our physician colleagues, and other barriers for FND treatment gets to be that there's the patients and families have limited access to folks who have that experience with FND, especially pediatric FND. Then this lack of education and competence and that kind of feeling self-efficacious in treating it, coordinating the bidirectional communication, right? So like not only thinking about us as experts speaking to the patients and families, but how are we making sure we're listening to what they're sharing with us too? And then that financial support for if it's not, you know, demonstrating medical, you know, kind of etiology, then how do we get enough support for it, or using all of these resources and all that kind of elements that add up to the barriers. But different factors that we can tap into, hopefully, to improve prognosis, being able to work together to come up with a timely diagnosis instead of that kind of pushing and only just like kind of bunting it around person to person, helping them get appropriate treatment for it. Getting folks connected to behavioral health as best as we can, noting, again, different barriers there, and coordinating the communication amongst different members of the care team. All right, so I'm going to turn it over to my colleague, Dr. Montano.
On the slide before, he talked about barriers to treatment and FND, and that was based on a survey of 2 different pediatric hospitals. And I think if we did that survey here, we would probably come up with the same barriers, right? So we didn't have a research study, but we saw that and we experienced that. So together with other stakeholders, all these people here, we all got together and created a FND clinical guideline, and it was approved in September of 2023. We worked on it for over a year. And this is just really the first step, right? It's about, again, getting us on the same page. We talk about having a huddle after we all do our evaluation, just to, what are we thinking is going on? What's our treatment plan? And I think even us having a panel represents how we need to collaborate with each other when working with these patients. Yeah, so this is just the first step, and we would really like to have a clinical pathway eventually, right? That even taking us from what does it look like when they come to the ED and what are we doing outpatient? It's a big task, but you know, I think the more and more we work with these patients, we think it's needed. So let us know if you're interested in working on that. But this, you can find this on the index, and we won't go into too much detail, but a lot of the information that we'll present today, you can find in the clinical guideline as well.
So making the diagnosis. Oftentimes, these patients come into the ED or the clinic and they have this plethora of symptoms that you hear about. The most common ones include headaches, sensory changes, chronic pain, balance issues, weakness, vision changes, abnormal movements, or speech and swallowing problems. Of course, this is not a comprehensive list, but I can understand, being a resident just a few years ago, it becomes daunting to kind of weed through. So I think this is the most important part of making the diagnosis, is gathering the information and how you organize it. The biggest thing I want everybody to take home is, please don't bias yourself with someone's prior medical history. We often, when patients come to the ED or we get referrals in clinic, we have medical history that often has psychiatric components that then start to kind of flavor what we think is going on. And I think these patients deserve a thorough history and physical every single time. One of my colleagues up here told me when I was a resident that the symptoms are distressing enough that they come out to seek out your knowledge and assistance. So I think we owe them that due diligence. I often create a timeline if the patient has multiple symptoms. So like I said, you might have 3, 4, 5, 6 things that they're mentioning. And so in order to kind of stratify, what came first, and then start to ask questions. When did it start? What are some of the things that you felt? Like, is pain involved? What workup or treatment was done? Oftentimes these people may have seen multiple specialists before coming to your door. So you can, if you create a timeline, you can see what has already been investigated and do you need to repeat anything else? Did the symptoms resolve or progress? Oftentimes in my general clinic, I'll notice that these symptoms may fluctuate. They wax and wane, or they may feed into the next symptom. And that can give you a clue of, is there something organic going on as well that you need to investigate? So this is how I tried to structure it. And then leading up to the next point of, I will ask them, what is the most concerning to you? And that's to set the groundwork that this one visit, I'm not going to solve everything, but I will focus on the 1 or 2 things that is causing you the most distress. It takes time to do this. And I understand that we live in a model that rewards efficiency. But I've noticed that if you are able to build out rapport with your patient, get a sense of what's going on, there's a lot of trust that they then offer to you. And taking that time includes your physical exam. Based on what is the most distressing symptom, I will often tailor my exam. For example, if they have gait issues, doing sensory testing, checking reflexes. But as I'm conducting the exam, I will also be telling them out loud, what does that mean to me? So intact reflexes indicate to me that your spinal cord is working well. Sensory issues make me reassured that there is no peripheral nerve issues. And so I think when you actually vocalize, this is what this exam means, rather than just completing it and moving on, they trust your medical knowledge in that way. I then, at that time, you were able to kind of distinguish what diagnostic study would you like to do? Would you like to do an EEG, an MRI? But at that moment, I also take that opportunity to introduce, would you be open to meeting with some of my other colleagues, including psychology or mental health? And so that way you can coincide what your treatment plan is. I often offer a follow-up within 3 to 6 months. And I know, again, we often think of, if I'm not going to get any studies or, I'm not concerned about anything, at least you are someone that they can reach out to and ask questions, rather than maybe representing to the emergency department. And oftentimes in that interval, if they've established with psychology or mental health or psychiatry, you can actually see their progress where they come back and say, I was able to work on this, or I've identified this, and this is how my symptoms resolved. The big takeaway that I tend to practice is, if I eliminate all of their past medical history and just look at what their symptoms are, would I still diagnose them with FND, or would I do some more workup? And I think that has helped me a lot. So we are a community that is working on trying to essentially set up ways to examine these patients. And I think the two most common things that we see at PCH include functional movement disorders as well as PNES. And so I'm not going to, talk about every point here, but there are things that we ask about, and most importantly is kind of the inconsistency of symptoms. There's also different exams that you can conduct, which then lend to your diagnosis of a functional movement disorder. There's also charts available online for functional seizures as well. And I think the big thing that we also want to mention today is you can have coexistence of FND and organic pathology. There have been multiple retrospective studies done where they've compared PNES and epilepsy, and almost up to 50% of patients can have both. They've actually made the distinction of sequential epilepsy and PNES versus simultaneous epilepsy and PNES. Sequential is essentially when you have an epilepsy diagnosis that precedes the development of PNES. It often occurs in childhood and adolescence. And these patients often have well-controlled epilepsy with their seizure medication and then develop PNES afterwards, versus simultaneous means that you have, they're existing at the same time. It may be a learned behavior correlated to kind of the psychological social dependence on having a disability from epilepsy. And the most reliable test, which we're lucky enough to have at PCH, is a video EEG. So I know that as neurologists, we try to document, a history. We try to define different types of abnormal movements. And we really rely on you guys as our pediatric colleagues to gather that history for us as well. Mostly because if there's inconsistencies in what we're hearing, your exams matter to us. Sometimes people will laugh and say, like, no one really cares about the exam that I'm writing. We do. We actually go through it because that's things that we pinpoint as well. I understand that the term has neurology in the diagnosis, and so we're here to be your colleagues and help with that diagnosis. But oftentimes you can articulate, your hunch, if you will, about, I hear your symptoms. This is the test that we're going to consider. We're also going to talk to neurology, but, would you be willing to also speak to some of our other specialists?
This table is from a paper, it's a consensus paper for physical therapists, but I love it because it really illustrates that FND has biological, psychological, and social factors, right? It's not just the psychological column, and the psychological is not the only precipitating factor. So it's not just anxiety causes FND, right? It's really a combination of all of these factors. And like Dr. Kahlon said, it takes time to gather this information. And when we're doing inpatient work, we can help with the psychological, social piece of things, and we can put it all together. But we're always thinking about the biological as well. And that can even include, when patients tell me, well, I'm not stressed. Hey, but you haven't been sleeping for like a month. Your body's under a lot of stress, even thinking about that piece of things. And this is kind of like when we train our trainees, we talk about this table and always thinking about like the biopsychosocial model, what are all the factors that play, and then what are predisposing, what are precipitating, what are perpetuating. So for example, we talk about secondary gain, but for FND is not, I am faking that I can't walk because I don't want to go to school. However, being able or not being able to go to school might be a reinforcing factor or a perpetuating factor, if that makes sense. So I'm not doing it, I'm not faking it to get that, but then when that's happening and school is stressful for me, it kind of reinforces my symptoms. So just thinking about keeping this table in mind when you're meeting with these patients and thinking about where are all the factors. And I think because there's so many factors contributing to FND, that's why there's so many team members, right, in the treatment of these patients as well. Now we're going to talk about a case presentation. Oh, no, just kidding. It's me. So just important considerations. FND is not a diagnosis of exclusion. I know this is maybe you've all been trained that way, but now in 2025, we know it's not a diagnosis of exclusion. We didn't find anything, therefore it must be FND, right? It's like Dr. Kahlon said, there's inconsistencies between FND and organic known neurological diagnoses. It should not be made this diagnosis just because all tests were normal, not just because they're weird symptoms. It really should be based on the overall clinical picture and positive findings. So some of the things that were on the table, Dr. Kahlon presented, like Hoover sign, hip abductor sign. You probably know more of this than me. The tremor entrainment test for like tics and motors symptoms. FND diagnosis does not require there's a specific psychological stressor or traumatic event to trigger the symptoms, or that the patient has a lack of concern about the symptoms. So some of you might have heard of the Bell interference. There's actually no research evidence to support that, and we don't really talk about that anymore. It does require positive observable symptoms that are incompatible with no diagnoses, and appropriate medical workup like we talked about, and then thoughtfulness on how to validate these families and patient symptoms. Like Dr. Kahlon said, at the end of the day, these are real and it's impacting their functioning, and they deserve as much care and attention as other patients. And FND is not factitious or malingering. These are different disorders. Yeah, and the symptoms are real. That is a huge takeaway point. Now we will talk about a case presentation to illustrate what we've been talking about.
All right, good morning. It's a short case presentation. And we have just some disclaimers. We changed the name, but everything else is a true story. So she's 15 years old, they call PG, with no reported past medical history, who woke up one day and she left out from the bed to sitting and standing, felt a pop, and then started having pain on the right side of the neck, on the lateral side. Then she had some trismus, difficulty opening her mouth. She was with those symptoms for 3 days, and then she decided to come to the ED. At the ED, they assess all the symptoms. There are the pertinent negatives there. In the physical exam, she has tenderness in the area that she was related to, and trismus that she can only open the mouth like 1 centimeter or no more than that. They did some workup, some imaging, and nothing was positive besides a reverse cervical curvature showing more of the tension of the muscles that they were contracted. She was sent home with muscle relaxants and followed up with a PCP. That was at Phoenix Children's. 3 days after that, she went to a different ER with exactly the same symptoms. She got admitted to a different hospital at that time. They consulted 2 specialists. They did more workup. They didn't find anything positive in the workup, and they decided there is no intervention that we can do. We think at this moment we cannot add more things to you, and we would like to send you to Phoenix Children for Botox injection. The other things that they tried was baclofen, gabapentin, diazepam. You have all the medications there. Nothing really helped her. At this moment, she also have not only neck pain, but headaches, occipital headaches, and some pain and numbness in the shoulder. She was sent to Phoenix Children. She was in that hospital for 6 days. Then she was transferred to us. The progression of the symptoms, besides that I mentioned before, the trismus were even more severe. She had more hypertonicity of the muscles to the point that when they tried to feed her, even with a syringe, she would contract the muscles even more. Mom noticed that she had some facial edema in the submandibular area on and off. And I'm just adding all the positive signs that are different in a way that we are just adding to the story and not repeating the whole story. For the consult that she had neurology as a consult. They thought at the beginning this can be an acute dystonia or can be a functional neurological disorder. They also added more things to the story. They got that she had 2 surgeries the last year in the knee for probably she has hypermobility and she likes to play tennis. And I'm adding this because every piece of the puzzle is important for this type of patients, or any patient in particular, any patient in general, but in particular for these patients, because it's, in a way, we are presenting the story. The patients, they are not physicians, they are not psychologists, they don't know what they don't know. We are the ones that have to take the story from there and put it together. So psychology then was consulted, and that is a lot of information there. Just to make it short for you guys, you can read everything, but there is a history of chronic pain in the family. She has friends, she plays tennis, she managed 2 sports teams, she is super busy until 8 p.m. with activities, she is in AP classes, she denies anxiety, trauma, suicidal ideation, she denies everything, but she said, Mom, maybe I have some symptoms of anxiety lately and difficulty breathing, but you have to pull the information from her. She tends to do things on her own. She doesn't want to bother other people. She doesn't want to ask for help, and she tried to avoid conflict. And you can see that somebody tried to avoid conflict, somebody that tries to do everything, is a higher achiever, might not realize that she's anxious or under stress. Sometimes we don't realize what we are doing, and it's other people that are noticing. For example, I might think that I don't have an accent, but you might differ from that. So same happened here, right? So other consults, the acute pain team was consulted. They suggested baclofen, gabapentin, and referral to our MDC. Speech therapy, PT, OT, workup was done one more time. They added an EMG that was absolutely normal. The other symptom that was added through the stay is the chest pain with pressure, non-reproducible. It was worse after a walk. All the studies were negative. And Mom said, well, this happened in the other hospitals a few times also. And the note said that the chest pain was consistent with anxiety. The treatments at the beginning, because she couldn't eat anything, she has a TPN, then she has an NG tube. When she was discharged, she didn't have either. She received speech therapy, PT, OT, psychology. The final diagnosis was FND. The hospitalist team discussed with the family, and I might say they did a very good job. When I saw the patient months after, they didn't have any questions about the diagnosis, but they wanted to have more help. The disposition was to be sent home. As per neurology, this all those medications, add muscle relaxant and NSAIDs, and follow up in the clinic in 4 months. For us, for pain, the referral was for the MDC. Our waiting list is 3 to 4 months, and no other follow-ups. All that happened in 4 days when she was in the hospital, which is a pretty short stay, I might say. Then we moved forward 2 months after the diagnosis. She presented to the ER with new symptoms, seizure-like events, like you can read there. The main idea here is that she couldn't control her body, but she was aware of everything that was going on at the same time. Those are the negatives, no workup done. She was diagnosed with pseudo seizures, and the disposition was to send home. I might say that from this moment on, and I review the whole chart, every single time that there is an HPI, the first thing that said is patient with functional neurological disorder. And I do understand we have to put that diagnosis like we put any other diagnosis, but be mindful that don't be biased toward that when it's right there at the very beginning. Like we said before, a patient with functional neurological disorder can have other things. It's not all together, it's gonna be only FND. So let's move forward. 3 months after the diagnosis, she had a consult or a visit with neurology in the outpatient. They added the symptoms. They characterized all the symptoms. And they said, well, we think that these are tic-like behaviors, non-epileptic seizures, seems like it's FND. They gave some links for psychology for FND and follow-up as needed. No other follow-ups after that for neurology. Then they came to our clinic 4 months after the diagnosis. These are the things that I just added, having the luxury to have an hour and a half to talk with my patient. the sudden onset neck pain is the same. What we took extra from that is the position that she was at. And we asked her to do the same that she was doing when she felt the pain. And what she did is, if she's laying down like this, she lifts the whole body with the neck, only with the neck, doing this. And you can see how these muscles are gonna be more contracted. If you add to that, she plays tennis and she's right-handed. And she's an overachiever, so she's gonna go for it as much as she can. So more things on your right side, more contraction on your right side. Then she went to PT the exact same day when the symptoms started. She went to PT before and the knee recovery that she was going through. But I can think of when she was doing some PT exercises, because she's used to use her neck and contract with everything that she does, she will add more on top of what she did in the morning. So the other diagnosis that we added, we knew that she had knee surgery. Now we know there was 2 surgeries the same year when she had the symptoms. She started with the FND symptoms or the treatments a month or 2 months after the second surgery. So you see how many stressors she has through the year and the other surgeries. For the physical exam, I already mentioned tenderness. It was more marked in this area here. When we try to do anything against resistance, any movement, lateral bending, side bending, it was super painful and can reproduce numbness and tingling in this area. So we did other tests, distraction, compression, everything was negative for that. But the Adson test, that is for thoracic outlet syndrome and can be vascular or can be the scalene syndrome, that is more the muscles that are here, anterior scalene and middle scalene, the brachial plexus goes through them. And these 2 tests, it shows you if there is any compression in that area. For the Adson test, you are pretty much like this, and go like this. And we reproduce the symptoms for paresthesia, nothing with the right radial pulse. And root test is like this, and you have to just do this for 3 minutes. She had symptoms like 30 seconds after. So, and this is the assessment. And I want you to pay attention in the way that I'm writing the assessment. I explain the mechanical part, and then I add the neurologic symptoms. And we do it in a way that I can explain part of that. And I mentioned then your nervous system is more, it has more stress, thank you, activated, thank you. Activated at this, we usually do it together. It's more activated, and that is creating other symptoms. If you can see, one, I believe is true, and second, this gives us a more buy-in from any patient and the family to understand why you said it is in my head when I clearly feel it in my neck, right? So if you give something, then they can understand more the other parts of what is going on here. And we're gonna talk more about that in a bit. So, and as an extra note, I added the hypermobility part that was mentioned before, and she was diagnosed later. So my recommendations were physical therapy, manual therapy, specifically myofascial release, low-dose naltrexone for the pain that she had, psychology follow-up, Center for Resilience and Wellbeing also because she has some triggers for that. The follow-ups were a month, 2 months, and 3 months after the pain intake. Her neck improved significantly with myofascial release, to the point that she decided to say, I don't think low-dose naltrexone is doing anything, and she did see after a few months. She was working with psychology and still is, and the body pain continues. But I might say that body pain, she has hypermobility. She had 2 previous surgeries, so it's a lot of things that's going on there. And she, to this date, she still didn't do physical therapy in the way that we wanted. So there are some things that are still triggering, and there is a reason for the chronic pain. And I don't think it's related to FND. One more time, a patient can have more than one thing together. So fast forward 9 months after the diagnosis, she had 1 ER visit, same jaw symptoms. And then 1 year after the diagnosis, same jaw symptoms. And in the notes say that she had here and there, not very often. They usually manage at home. So they're still present, but not as present as they were before. And this is pretty much a timeline that we have with the first symptoms. Point zero for me is the diagnosis in our hospitalization. Then 2 months after that, one ED, 3 months after that, a neurology follow-up, 4 months after that, the pain clinic. And if you see what is in red there, she added more symptoms in that time between the hospital admission and the follow-ups or evaluations in the other clinics. And I think it's important to notice if we can improve that time gap, I think we can help them better. And I think that's the last one for me. Next one.
So what do we do with all this information and what can we start doing today? There's a lot, like we said, and this is really touching the tip of the iceberg, but the things we'll talk about can really make a difference. You know, I think we've been talking a lot about trust, validation, and that goes a really, really long way. First, consult us, consult your colleagues, build that multidisciplinary team to target all the different factors that are impacting your patient. Also, let's change the way we talk about it, right? This matters a lot. So for example, your MIO is normal, there's nothing wrong with you, you're fine, or it's just stress, or you just need to work with a psychologist. What does that lead to? Feelings of like, well, I don't feel fine, or they think I'm making this up. They think this is all in my head, or they miss something. Are they not doing all the right tests because they think I'm faking it, or they don't believe me? What does that lead to? More activation of the autonomic nervous system. They won't follow recommendations because if I don't think I'm safe, why would I go to physical therapy, right? Why wouldn't I go to the next hospital to look for more tests? So making the diagnosis and getting the buy-in from the family is a huge, extremely important step. Something I wanted to say about the multidisciplinary team as well. And the clinical guideline, we outlined who you should consult right away. And we are one of them, psychology. Because what we were seeing a while back is that we didn't find anything, here's psychology. And then families were just really not, you know, there wasn't that much buy-in. They weren't too excited to work with us versus like, we think all these factors are impacting your symptoms. We're gonna get all of our, you know, colleagues together, specialists to help you out with all of these things. And in the guideline, we talk about ways, can I give you suggestions on how to introduce that multidisciplinary team, how to introduce psychology as well. So yes, I always say, if the family doesn't buy in, anything that I say doesn't matter because I will talk about focus on functioning. Let's do more, let's do this. And if they don't feel safe and they don't have that trust, we can't do everything else that we need to do. The next one's a little bit of a call to action, and I will include myself. Let's change the way we're talking about it, right? Like the terms unexplained, pseudo, psychogenic, behavioral, stress-related, conversion. These are all outdated terms. And they communicate, this is not real. They communicate like behavioral, you're doing it on purpose, right? It's a behavior that they're under their control, or we haven't done enough tests. Like it's unexplained now because we haven't done enough, or, you know, or it's just due to anxiety. So for example, psychogenic non-epileptic seizures, I still use PNES and it's so easy. But I think if we take a step back and think about it, like what are we communicating to our patients, right? So I invite all of us to start thinking about how we talk about it and how we can change the way we talk about it.
I have like a quick comment. This is like an ongoing discussion in neurology as well. And so PNES, I think, is the old term that we use in a lot of our papers. The new term by the ILAE is functional seizures. And so, but of course, that's been the historical nomenclature. So I think there's going to be a continued evolution.
Yeah. And it's easy to use, but I think we can all make that effort of like, okay, what are we going to SPCH? What do we want to change and call it? Just to have more of that validation and trust from the families. Talk why validation matters.
Yeah. If you know me, or if you've spoken to us, it's like validate, validate, validate. Right. It doesn't mean that we excuse or that we are just like kind of placating, but how do we be authentic and validate at the same time? Because a lot of times, again, the patients are denying any significant other history of symptoms. So it's like, well, what the heck? Like, why am I going to see psychology if I'm not anxious or depressed or have any other of those kind of problems? And it's where if we can talk about the autonomic nervous system, then I think we can not only help them feel validated and heard, but we can also like kind of understand that and feel that empathy as well for what's going on, right? If I'm like sweating and I'm turning red here, talking in front of a group of people or whatever, did I do that on purpose? No, right? Would I prefer not to maybe look like a sweaty red lobster? Yes. And how do I do that? By working on my skills and helping to kind of practice, you know, getting up and doing different things. So that's where we can be as psychologists, not just treating things like anxiety or depression or trauma and focusing on that, but even helping with the regulating of the autonomic nervous system through our different coping skills. How do we learn to cope with having FND and kind of like function in our day-to-day, improve our health behaviors, ranging from the sleeping, eating, exercising, and improving functioning overall? Is it like doing just a little bit at a time? Activity pacing is a big piece of what we do. And how do we bring in more of the positive reinforcement like that we can help to promote the behaviors we want to see? So it's not just treating about treating these comorbid psychiatric conditions. Oops.
Yes, okay. I just wanted to go over cognitive behavioral therapy. This is the most commonly used approach for FND. And you know, we talk about the connection between thoughts, feelings, and behaviors and our physical sensations. So like Dr. Zakaryan was saying, when you introduce psychology or when a psychologist works with patients with FND, we're not just treating trauma, anxiety, depression, right? We're really working on thoughts about FND, right? I'm not safe if I walk this, I'm gonna fall, versus like my body is safe and I need to, you know, work on that mind-body connection. How do I feel about it? It's always hard. You can't change your feelings. It's hard. We work on the thoughts, behaviors, and the physical sensations. When my heart starts racing, what can I do to calm my body down? Behavior, I'm just in bed all day. Okay, we're gonna start, yeah, like he said, focusing on functioning, getting out of bed, going to school. So we really target all of these, even just around FND. We're not even getting to the, if there is comorbid anxiety, depression, trauma. So if your patient has an FND diagnosis and there's really like no anxiety, no depression, how do you get that buy-in for psychology, right? So we can really work, like I said, on the thoughts, feelings, behaviors, and how our body feels in relation to FND. We work on increasing that awareness between the mind-body connection. Like, oh, actually, I noticed that my hands do start shaking when X, Y, and Z happens. We talk about the stress about the symptoms, anxiety about functioning and symptoms. So we can really focus on the FND piece. And of course, we worked on emotional factors as well, increasing that insight, increasing comfort with emotional expression. I think a lot of us have seen those patients who keep it all in, and that adds to these FND symptoms as well. Our goal is to work on helping them improve functioning of, I don't want to go to school using a walker, you know, and working on that comfort with the patient. We definitely address secondary gain if there's any, you know, of like, no, we are going to go to school. You are going to do chores as much as you can, that kind of thing. And yes, if there are psychiatric comorbid concerns, we will help address them. And those could be, you know, CBT, DBT, ACT. But I think hopefully this gives you more of an idea on how to introduce psychology, especially for those patients who are not just saying, well, this is not just anxiety, this is not just stress. It's like any new diagnosis, right? We get consulted for coping with, you know, IBD or diabetes. It's the same thing. This is a stressor in their life, and how are they going to cope with it?
So some take-home points before we kind of get into the question and answers. And so kind of framing it with perfect is the enemy of good, right? So we're not going to be striving for perfection. We're going to be working on improving the clinical guideline and kind of editing it and expanding it, and also thinking about how do we give one another grace when there, you know, is pressure times and other kind of like things that are going on in our system and for our patients and families. So we kind of keep that in mind. Again, just because it's not perfect doesn't mean it isn't useful. So how can we utilize the clinical guideline? How can we utilize our colleagues, or how can we utilize the information and knowledge we have on the, you know, appropriate sources on the internet and different things like that? Having an open mind with these patients, aka and any and all patients, right? So kind of making sure to not be biased by that previous medical history, because we definitely have, and another, you know, big takeaway or something that has been a big impetus for us and motivating factors, that we've seen folks who also get a diagnosis of FND and have passed away from other things that could have been prevented, or get a demyelinating condition, and things were missed. And so we want to make sure to be preventing that. So coming at it with curiosity. So how can we kind of infuse that more and that authenticity that comes with that? Taking the time to listen and knowing that we are, as the clinicians, as the experts, we're making those clinical connections, like Dr. Genovese was saying, like Dr. Kahlon was saying, and it's not about the patient family doing that, as if they're gonna kind of piece all that insight together right away. Again, language matters. So being strategic and thoughtful about the language that you're using, being mindful, being validating with how you're talking about their symptoms or listening to what they're saying, kind of integrating how all those different symptoms could affect one another. Like from our case presentation, if you are like leaping out of bed, or like, raising yourself out of bed, okay, now we can kind of put those mechanical pieces together, muscle tightness, and how that can lead to that numbness. And so how can we help kind of bring that elements for the patients together, and knowing that treatment isn't linear. So again, right, we saw from our case presentation that it wasn't just like, oh, now all the symptoms are gone. No, there were some ED visits, but it just wasn't as bad as before. So how can we kind of use our language to suggest that there's different ups and downs, and that's normal, especially when it comes to FND, and that we're not like focusing on a cure. Again, we are in a system that focuses on that kind of approach, but how do we improve functioning and like kind of bringing that focus back to that if we know that we've done all the other pieces and now we're at that kind of treatment phase. And phone a friend, right? So kind of reaching out to other colleagues, especially within Phoenix Children's, or if being outpatient, how to get in touch with folks and like kind of have another set of eyes, ears, or other specialty to kind of help support you, right? And then some different helpful websites that people can be scoping out to get some info on. And this other resource that is available out there as well, and our references. And thank you to everyone, and going to open it up to questions. Anyone here? Yeah.
I guess I'm wondering how you would navigate the conversations around kind of over medicalization, and like when you have a patient with functional neurologic that's admitted and they're asking for all these things, and they're like, well, why can't we do 5 days GE? Like, what's the harm? What's the harm in doing all these additional workups, or what's the harm in consulting ENT for this pimple in her ear? And you're just like explaining things, but they don't really accept it. Like, how do you navigate those conversations?
I think I know exactly what patient you're talking about. We should.
You were there.
So like we mentioned, like each of our specialties can talk for hours. Just kind of tracking back, I try really hard not to say the word normal when I like talk about a diagnostic test. I will use the language of your MRI shows me that your brain structure is intact. And so you have the capability to do XYZ, or your EEG does not show any abnormal brain activity. So during this period where you were having these movements, your brain was not going through any like detrimental changes. And I think that if I've gotten a lot of good buy-in saying that. Yes, there are certain situations where families may push for more testing. And so that is why I try to hone in on like, what is the most concerning thing of why you're in the hospital? And if you can answer that question, right, the pimple in the ear was not that person's biggest issue. It was their, what we found was non-epileptic movements. And it's not easy. I know what it's like to be on that side of a conversation. And that's why you have us. Like if multiple people are saying the same thing, if we all kind of huddle together and, you know, make sure that we're all kind of using the same language, I think it helps. So.
That's helps, but you have to know that we are all different, and there are some families that no matter what you said, they're still gonna go to the first second opinion. And I will say, always leave that door open. Because nobody likes to feel trapped. As in, these people are not listening to me, and then it's going to be a situation that is unfriendly. they're not gonna hear you anymore. So leave the door open. Say, this is my professional opinion, but please feel free to look for a second opinion. I think this is what they're gonna find. I don't think they're gonna find this, but if that makes you feel better, please look for one, because you cannot stop somebody. And if it's a child that having symptoms that nobody can understand, most people at the beginning say, oh my God, there is something else, right? So just remember that it's not gonna be perfect, but depending on the language that we use and how we approach, most of the patient will understand us. And the others might go and then come back.
I agree with Dr. Genovese. I've had that experience as well. I don't take it personal. I think that's the biggest point of, yes, you can go speak to other people, but this is what I feel, or this is what I think.
I had a similar question, but I'm going to modify it slightly, thinking of a particular patient in mind. But I don't think we always communicate like medical teams. Like sometimes I feel like one team is de-escalating while another team is still going on. A diagnostic odyssey or kind of escalating. And I don't know if you have any opinions. I mean, not that that's always inappropriate, but sometimes I feel like it does add to the frustration for families because they're getting an inconsistent message from their teams. Like, how do you feel like we might give a more consistent message?
It's more outpatient.
It crosses the boundaries with the particular person I'm thinking of, but
it takes time. I think the only way that I've found that is I actually reach out to that individual maybe before the appointment or after. I like leave the door open of let me talk with the other specialist and then I can get back to you. Yes, you may have to call the patient back or communicate with your nurse, but I found that at least I can understand what the other practitioner, why they're doing what they're doing. I don't know if that answers your question.
yeah, I mean, I think in an ideal world, we would have these like care conferences and get everyone on, but particularly in the outpatient setting, that could be quite challenging to arrange. And then sometimes we don't want to write things in the note that are what we're actually thinking because families might read it or we're not 100% certain or whatever. So like, I do think sometimes communication, particularly in the outpatient setting, is hard, but then it leads to a lot of frustration for families.
I agree with you. I think it's on us to communicate. It's not on the family to deliver the information to the different providers. It's absolutely on us. And if we have a pathway in the outpatient, I think that can help. Doesn't have to be an MDC with everybody together, but at least some specialists that they're going to assess the patient and they communicate with each other. Something like that might help.
Yeah, it's good. I'm personally trying to send a lot of like messages to all the specialists, so I apologize if you're getting them, but just with my actual thoughts or what's going on when I can do full care conference.
And I think in the clinical guideline, we talk about having a huddle, like I said. It's hard to do. Everyone's so busy. No one's paying extra time to like give you that hour and a half clinic visits, outpatient. And it does go a long way to all of us get on the same page as like, we're a united front and you can trust us, right? Versus like, wait, this other doctor's doing these other tests and I don't trust you, I trust them. And that's really hard. And I don't know how to fix it because we have to work within the system we're in. Yeah, but definitely, yeah, communication. That's the only thing I can think of. And I know we're really trying to build it into like the guideline and hopefully a clinical pathway in the future.
Yeah, I mean, I think, I was gonna say, I think that's like our long-term goal, like kind of like having like these kind of like future goals of like what can be done outpatient. We just knew that we could control more of the inpatient side. So we started there. And then how can we expand to the different touch points that these patients are having to kind of hopefully de-escalate or minimize the medical healthcare utilization and all those kind of things and hopefully get them treatment faster. And also soon something that'll be coming out as like hospital-wide, hopefully, again, is like more of like, we have our comfortability program, which is like a day-long workshop that helps with the different chronic symptoms, and that can include functional symptoms. But we have to get all the kind of things in place with outpatient order sets and other things. But when that's out there, we'll kind of let everyone know.
That's for patients.
Patients and families, patients and caregivers. Yes.
So question from the chat, is there differential diagnosis with malingering or factitious disorder or not?
There can be.
Yeah, it can be.
So I think you see more of them. Maybe I don't know.
I think our automatic in the hospital, at least we believe the patient, right? We're not thinking about malingering, we're not thinking about factitious. And a lot of times it reveals itself long term in the long run. But yeah, I mean, yes, absolutely, that can be a differential diagnosis, especially if we're noticing very suspicious symptoms. So yes, I would say yes, and it's not the same. I don't know if you want to.
I just think of a patient and situation where that was written, that was written in the chart as a differential, and this parent caregiver was a medical healthcare type provider, read it in the chart, and then it became a problematic issue if you're not having everyone agreed upon that. So I think it can be in the back of one's mind, but again, if we're coming at it where you're not believing the patient, what are we going to do? Get into fight, flight, freeze. What is that going to do? Escalate the symptoms, and then it just kind of perpetuates that cycle. So how do we find the ways to validate, but still like have boundaries, right? It's not like you get an MRI, you get an MRI, you get an MRI, right? Like, we want to be careful and thoughtful, and make sure that we start off with the validation and then try to put the pieces together.
I have been in scenarios where I have had to do an exam separate from like a caregiver or a parent in the room. I have the luxury of having residents who may be able to pull a parent or a caregiver outside of the room to get more history, and then I can do the exam. And there are scenarios, I think, with that differential that you may have to do that.
Any other questions?
Thank you.
All right. Awesome. Well, thank you everyone for your time. We know it's not easy, and so we appreciate everyone's engagement.
You're